Or we could do it through the groin if we're doing ablations.
Oh, so you could do it from inside the blood vessels.
If we're doing transeptal punctures, when we punch a hole in the heart temporarily to go across to the other side.
We're going to get to that in a second.
Okay. Yeah. But the one that we primarily do is the transthoracic echo, where gel is on there, put the microphone up, and we will be able to see all the 4 chambers of the heart, and the left side, the right side, how large they are, how well they are pumping, how much leakage there is in the valves. Are the valves normal? Are there 3 cusps on the aortic valve? Is there stenosis of a valve? Is it calcified? Is it stuck?
And then the other thing you like to look at is the aortic root, because we get a lot of patients say, oh, you've got an aneurysm. What is just while we're there, what is an aneurysm of the ascending aorta, which I see a lot of reports, and you've got to get tracked and you've got to get followed. Okay. What's the risk and what is it?
Okay. The best example of an aneurysm is if you leave the water pressure turned on in the wintertime, although you really don't get winter down here. In Georgia, we do. Your hose freezes. And then in summertime or springtime, you turn it on again. Now, all of a sudden, you notice, even though you still got pressure, your hose now, it looks like you've got a snake that swallowed a rat. And that's because the inside has been torn and destroyed due to pressure. In this case, it's a hose, but in your aorta, that's the big hose coming out of the heart. And if you have years of high blood pressure and maybe your collagen synthesis isn't good and you aren't repairing the collagen there, you will now start to, at the high pressure area, stretch out. And again, yes, you get cardiovascular disease there as well. You get plaque. So once it gets stretched out more and more, there's a certain point where it's going to keep stretching more, and then it's going to burst like a balloon.
And what is that point? Because we see above 4, above 5.
Yes.
You measure the diameter of that.
Yes, you measure it generally from the inside walls. The upper limits of normal is 3.6 centimeters.
Irrespective of height and size.
There is a correction. If you were, for you, I would give you 3.7, possibly 3.8. For someone more petite, then it would be a little less. There's actually a formula for it. We tend not to use too much, but the main thing we look for is it within normal limits? And if it's within normal limits, then if it's repeated in a couple of years, you look to see if there's been a change. If you have a change, you're at 3.6 one year, next year you're 3.8, like, okay, that may be something we need to look at again in another couple of years. Is it starting to get bigger?
And it's usually most commonly due to elevated blood pressure.
Yes, it can also be due to Marfan syndrome too.
Right, that's the collagen disorder.
Yes, absolutely, because like what Abraham Lincoln had, most likely.
And then the other question is, at what stage would you intervene? At what stage you say, okay, now we need to operate on this thing?
There's 2 things involved, both the absolute size and the rate of change.
What's the absolute size?
Absolute size is generally 5. Occasionally, I've seen 5.5. It depends on the
5
risk
is the
factor.
one that I'm used to.
Yes.
Yeah.
Yes, I know I'm talking to a surgeon here. So, but if we start to see a change where it's over a course of a year, it's gone up by half a centimeter. Then next year it's gone up another half a centimeter. That's much more concerning. They're not at 5 yet, but this is a rapid rate of change.
And the worry there is dissection, where it can
because when it's changing that fast, it could tear.
Yeah.
It won't just burst, but it'll tear. In fact, I use the example burst when realistically, as you pointed out, it's primarily the inside and the outside separate out, almost like your tire delaminating.
Yeah.
And that will cause blood to go in, and then it'll split the whole thing all the way down to your kidneys, and things end very badly.
And that's the dissection, whereas in the abdominal aortic aneurysm, we see the ruptures and that kind of thing.
Right, and you still can have dissections as well, too.
Yeah, of course.
But the dissections tend to kill more people.
Right. The other question I have for you is, with that dilation, with the stretching of the ascending aorta, where the aorta goes up, you've got the ascending, the arch, and then the descending. That is right above where the valve is.
Yes,
and does that stretch the... Oh, okay, let's talk about that. Does that also stretch out the valve and make the valve incompetent? And what does it do to the coronaries?
Not good things. It depends on how high the aneurysm is. One of the things we worry about Marfan's was that frequently there is a bicuspid aortic valve, not always.
Arnold Schwarzenegger had that.
Yes, he did. I know, you talked about that. Yeah. I remember that very well. And he had the Ross procedure.
Yes.
On there. And
twice.
Yeah, I didn't hear about
the second one leaked. It leaked.
Yeah.
And he had to get rushed back in and redone. He bled into his pericardium. So Yeah.
Yeah, those things I didn't know about that, but I did wonder how much of this was steroids, how much was it not, how much was this the tremendous back pressure when you're doing heavy powerlifting.
That's interesting. I've not thought about that.
It's the back pressure, absolutely.
Yes.
In fact, that's what we recommend if people have bioprosthetic
That's when you
valves.
squat and you hold your breath and you... Okay.
We don't recommend people that have had bioprosthetic valves. One of them is called TAVR, which is a percutaneous valve. Basically goes up like an angioplasty. We put it through, expand the valve in place. We use them for older people. They should last at least 10 years, sometimes longer. And you could even, if you put it in an 80-year-old and it lasts till they're 80, until they're 92, and they need another one, you can put in another one and it'll last until they're 102. But you put it on the inside, but they're not going to need one that's as big at 92.
But when you do that, doesn't that clog up or plug up the coronary vessels?
The way it is put on, in a way that the coronary arteries, they will get, it's called jailed frequently. And this is not my field of expertise right there and how those are put in. But you do not block the arteries, but it can make getting in to do a procedure, procedure is more difficult, which is why before a TAVR valve, we normally will do a heart catheterization or sometimes a CTA.
Right.
Depending.
CT, we'll come back to CTA.
I know. I know how you think.
So the next question is, and this is something I've seen a few times, and it's just like, what's going on here? Where somebody has ischemic heart disease, they've got a positive stress test.
Right.
And they've got a very low CAC score, and it's not a plaque disease. And they've been told that it is a coronary branch or a coronary takeoff problem. And they've had to have that surgically repaired. I had one actually in Georgia, a patient of mine from Georgia that had that done. Where I said, look, you've got a 0 CAC score.
Was this myocardial bridging?
I think that's what it was, yes.
Yeah, myocardial bridging usually does not require surgical correction. It is where the epicardial arteries, which means the surface arteries, don't always grow on top like they're supposed to. They grow underneath sometimes, and I'm sure
that's exactly what it was. Yes.
Where vessels don't go where they're supposed to.
Yeah.
And if it goes underneath, then as the heart contracts, it's literally going to squeeze off the arteries.
Dysphagia nosoria is the one that I deal with.
Yeah, and it can, if it's long enough and bad enough, it can trigger off cardiac arrhythmias. It can even cause a clot to occur there in a totally normal artery. And the best way to see it is either cardiac MRI or heart catheterization. You can see beautifully as it's contracting how it literally pushes all the blood out. And it can cause arrhythmias and a heart attack. And yes, occasionally.
How common is that?
It's a bridging requiring bypass is pretty rare.
But seeing bridging that is symptomatic.
Well, the question is how symptomatic
Let's say you've got a negative, you've got a positive stress test and no plaque.
Right. And you have, and the heart catheterization shows myocardial bridging. We initially will start by treating it with calcium channel blockers to help keep it dilated. Sometimes nitrates, sometimes ranolazine, which is we can talk about it another time.
Right.
And if you still are symptomatic, and you're also looking at the potential arrhythmogenicity of it, it's not something that we send very often, but it's going to be, they're not getting better. And because you're doing an open heart surgery, you're doing a single vessel Lima to LAD, the graft that should last for the person's life. But you want to make absolutely sure that they're going to feel better or live longer. Yeah,
and that was the, and this person had a wonderful result.
Yeah.
But he
sounded like he really
did. And it boggled my mind a little bit because he was, he's obesogenic, he had a 0 CAC, and yet he was having chest pain that was ischemic.
Which is why we don't ignore it. Even with a 0 calcium score, there are times you need to do a heart catheterization. And that's where there's a different disagreement with certain cardiologists when it comes to getting calcium scores. I'm also a nuclear cardiologist too. I have a lot of hobbies.
Yes.
So I'm boarded in that as well too. So that's why I believe that it's important. If you're a 40-year-old man, you should have a 0 score. If you're a 50-year-old man, maybe you have a little bit of atypical pain. The primary care doctor says, oh, we're just going to do a calcium score. Okay, fine. But well, you got risk factors. You may have metabolic syndrome. Blood pressure is getting up there a little bit. And your abdomen's a little bit on the big side. Calcium score is good, but that wouldn't be my first choice necessarily. if I think there's risk factors, because the most important thing is a functional study. That you have to, if you can get on a treadmill and you can walk.
Let me stop you right there.
Okay.
Let me stop you right there. Okay. So we're talking about stress tests, and you did, and I hear what you're saying about. First of all, I think a CAC score is a ubiquitous test like an EKG, because even if it's negative,
you like them at?
And you know what? I look at the person's body habitus. I look at what their risk factors are. If they're more diabesogenic, I'll start very young, because I want to see
40 or 35.
I would start even in the 20s. Okay. And the reason for that is because I want a baseline, and I want to. I'd rather prevent disease and say, hey, listen, you know what? You're 20 years old. You've got a CAC score of 80 or 100. That's a problem.
Yes.
So, but I don't. This was not about CACs.
Right.
Stress test.
Yes.
There's two types.
Yes.
There's the exercise stress test. Yes. It's about speeding up your heart.
Yes. Increasing your oxygen demand.
Okay, I like that. That's better. Yes. Right. There's an exercise stress test. There's a nuclear med stress test.
Yes.
And I've had cardiologists tell my patients, no, you must have a nuclear stress test. No, you can have an exercise. What difference does it make? And what is the different information you get from them? And what's the indication for one versus the other?
Well, there's actually a third one as well, too. But the stress echo.
Okay, yes.
It all comes down to sensitivity and specificity. Meaning, if you have disease, what's the likelihood of picking it up?
Okay.
The simplest but the least sensitive is the exercise treadmill test.
The simplest but the least sensitive.
Correct. Meaning I have the greatest chance of missing significant disease with a straight exercise stress test, because you need to have a blockage of a large artery of 60, 80, 90%. 60 usually not.
Is that because you can't exercise enough to produce the problem or to show the problem at lower blockage levels?
Yes, that is correct. You are not causing enough decreased blood flow. It's still decreased blood flow, but not enough to change the EKG enough.
Right.
It needs
so you're looking at an EKG, you're looking at the electrical function of the heart on a stress test.
It takes a whole lot to make that be abnormal. And in the old days where we could do a lot less, and it's a question about how much we're really doing nowadays, but that's another thing. But in the old days, a straight stress test, exercise treadmill test was quite useful, but it also gives us information. If you can just get on the treadmill test and you can exercise reasonably, 7 minutes, 10 minutes, if you can get the 10 METs or even 7 or 8 METs, which is a metabolic equivalent, you sitting talking to me now, you're exercising at 1 MET. If you exercise at 10 METs, which I'm sure you can, you do it all the time, that in itself is a highly important prognostic indicator for your chances of living.
Does it also reveal, does exercise or stress tests like that also reveal arrhythmias?
Yes, if you have other issues like atrial fibrillation, the catecholamines, the adrenaline can trigger it off. If you have a problem with your electrical system where it's not working all that well, and if you speed the heart rate up from 70 to 120, it just can't go at 120, it can't reset itself fast enough, and now you develop heart block, and your heart rate drops, and you drop too, like, oh, I need a pacemaker. So it shows the electrical system.
It reveals that.
Yes.
Now tell me, so we talked about the exercise stress test, and now tell me about the nuclear medicine stress test.
The nuclear medicine stress test.
That's where you inject.
You inject a tracer. It's usually technesium. It's a very short-acting 6-hour half-life, and it goes to the mitochondria. It goes to the heart when you are, and it locks in permanently for 6 hours when you are at a certain level of exercise or stress. The best one is you walk someone on the treadmill, you get them up to 85% of your maximum predicted heart rate, you inject the dye, it's not really dye, but the tracer, and it will tag that area of the heart for the next 6 hours or so. And if there is an area that's not getting enough blood, it will be much less. It won't be nearly as bright.
So you have a measurable of how much tag you expect to see, and the difference between that, what you actually see, tells us that not enough is flowing through that blockage.
We will also do a separate one resting, so when there's no stress to it. And we can compare the two on a computer to see this is a difference between rest and stress.
You do them at the same time or separately?
We do it separate times because of the half-life.
Right.
If it also shows if you've got scar. If you have an area with stress that doesn't light up, well, that could be ischemia or decreased blood flow, or it could be just dead.
From a previous heart attack.
Exactly. And by doing the rest test, they see, oh, there's blockage or there's a scar in both areas.
So you believe, if I'm reading this correctly, that the nuclear medicine stress test gives you better, more accurate, more sensitive information.
And specific.
And specific. Okay.
Because you can have abnormal stress tests where, depending if you look at the what's called the inferior leads, more commonly in women and certain people, you can have an abnormal test. This is abnormal, but the heart arteries are normal. So it is both less sensitive and less specific.
If you're dealing with a very fat person who has a lot of fat, and fat blocks electricity, how does that affect a stress test or EKG?
It doesn't affect the changes in the T waves and the ST segments. What it does is it affects the voltage. And also with sweating and with the increased insulation, there's going to be more artifacts. So you won't see as pretty an image. So that in itself, not having as good a resolution, is going to decrease the sensitivity of a regular exercise treadmill test.
And what is your indication for a stress test?
Chest pain, basically. And the question is what type of stress
test? But isn't chest pain a little too late? When you in other words, if you've got what I was asking about is if you have a positive CAC score, a CAC score above X number. I use 80.
Yeah.
And then I send people for a stress test, even though they're asymptomatic. Because once you're symptomatic, it's kind of, whoa, we're in trouble here.
Yeah. It is hard to do a imaging stress test, either a nuclear stress test or a stress echo. Although it's a little easier with a stress echo, but they're neither sensitive nor specific. Again, that's my opinion.
Yeah.
But the insurance companies are not going to want to pay for an expensive test when you can walk somebody on a treadmill. They still don't like calcium scores.
So if you're not symptomatic, you're going to... And a lot of my patients pay out of pocket. We can get them for between $60 and $159 and $150.
It's about $150 where I am.
And it gives us also ancillary information about what else is on the chest.
Agree.
So
it's very helpful.
We've picked up tumors, we've picked up other issues. So that's useful. In fact, one of my patients had a melanoma 20 years before, got a CAC score, and his entire one block of his spine was replaced by melanoma. He wouldn't have known that. Now he's gone through treatment, he's in remission, but we wouldn't have known that if I didn't order the stress test on him.
Yeah.
So, and this guy's in wonderful shape for his heart, but boom, we picked up. So anyway, I just want to put that anecdote out there. So what are your indications to do in an asymptomatic patient? What would your indications be to do a stress test?
We can do it would have to be a regular exercise stress test because again, it will not no imaging study will be responding. Sometimes, depending on the insurance, they may do a stress echo, which basically means you walk on a treadmill and you do the echocardiogram and you look to see if there's a serious blockage. That wall of the heart's not going to function well.
It's a wall motion again.
Yeah, and it's a wall motion.
But that's less sensitive.
It is, and that's the reason that we tend not to do it there.
Yeah.
And there's two schools of thought in there. But to do on an asymptomatic person, people that have risk factors, hypertension, diabetes, metabolic syndrome, generally there's going to be some non-specific thing that will bring them to the office. Sometimes it's EKG is a little abnormal. There's some T-wave abnormalities. I'm asymptomatic, but my T-waves are off. That could mean.
So if you've got a CAC score that's positive, like my patients, it's important to encourage them to be very detailed about any minor chest pain they may feel.
Yes.
And report that to the cardiologist, because if there's chest pain present, that's an indication to do a nuke med stress test.
Right. See, I like calcium scores because I think that they are synergistic and complementary with exercise treadmill tests and exercise or what we call chemical stress tests as well, because it gives combined information. But I am not, if someone has risk factors, they have a calcium score of 0, it does not mean that they don't have an anomalous blood vessel. It doesn't mean they don't have myocardial bridging. It doesn't mean that they don't have fresh, a lipid-rich plaque that hasn't calcified.
Right. That's okay. So let's talk about that. I want to get into the arrhythmias. That's really why we're here.
Okay,
but
that's fine. I got it all
no. But I want to talk about, and we may break this up a little bit. I want to talk.
I can make
this
up. Total fast.
No, absolutely. You brought this up. CAC score, which is a non-contrast CT scan of the chest, and you need a special program on your CT scanner to do that. It's software. But then a CT angiogram.
Yes.
What's the difference and what's the indication? and who should get a CT angiogram versus CAC score?
It is good to have a basic screening test, which is the calcium score. Essentially, they hope your heart rate is under 70. The lower the better. It gives a good resolution.
But you can slow that down.
Yeah, well, you give beta blockers.
Yeah.
And unless someone is really anxious, and I've had a few people that just couldn't get the heart slow enough.
Right.
And it will let us know if you have long-standing disease. If you had disease that's been there long enough for it to heal itself and to cause calcified plaque, or if you've been on statins, which is another thing too. So how?
Wait. Say that again.
If you are on statins, you will have a calcium score, most likely, if you've been on them for a period of time. Now you set me up.
No. Because I've heard this before. I know this. Yes. I know what you're talking about, but to hear it come out is important. So statins can actually contribute to a positive CAC score.
Yes, absolutely. And the argument, I'll say the orthodox argument for that,
consolidating the plaque.
Yes, you are sucking out the soft plaque, and you are now allowing it to heal itself.
Concentrating the calcium.
And making it a stable, non-mobile, non-vulnerable plaque. That is the argument. Oh, calcium score that goes up with time is good. Okay.
But that's because you're on a statin.
Yes, because you're on a statin. It's doing its job.
Wow.
Okay.
Okay, so the title of this is going to be Statins Cause Your CAC Score to Go Up. No, I'm not going to, we won't go there. But I mean, that is a reality, that's a truth. And it's been spun. We don't know the significance, but it's been spun.
Well, you can always hire me if I get fired.
Exactly. No, but that's truth. That is, and it's documented truth. Yes. So we're not being blasphemous.
It's not considered a bad thing either.
Right. Well, it's spun into not being a bad thing.
Right.
You know, just like carbohydrates aren't bad, it's smoking that causes plaque in the blood vessels.
Yeah, it's one of the four things.
One of the four things, right? So, but CT angiogram.
Yes. Okay. The CT angiogram is a lot more expensive. It costs about $1,500, $1,800 for us. So what the calcium score will give a basic freeze-frame, three-dimensional picture of the heart and places where there's calcium. It won't tell us more. It will sort of maybe tell us if you've got three arteries, if they're more or less in the right place, and if the heart's more or less right. It does a pretty good job of that, but it's not a high detail image.
Right. It's like a chest X-ray versus a CT scan or an MRI.
But the CTA, we actually will inject dye, and we gate it so that we can see the dye flow through, and we will see if you have three proper arteries. We'll know which one is the dominant artery. We will know if there's blockages. We'll know if there is calcium. It's in some ways a poor man's heart catheterization angiogram. I like to use it as an example of, it's like watching a VHS movie from the 1980s. If you're watching it, you may not be able to read the license plate when you hit pause. But if you have a Blu-ray, same movie, and you hit pause on Blu-ray, you'll be able to read the license plate beautifully.
Right, so it gives you a better read.
It gives you but the problem with it is that if you've got calcium, and you can't always tell what's inside the calcium. You can't tell if it's a 20% lesion or a 90% lesion. So there will be times with a CTA that, yes, you can see heavily calcified area, not well visualized, proximal LAD. Can't rule out serious disease.
A CT angiogram, you can't do a CAC score, there's too much scatter when there's a stent.
Yes.
And a CT angiogram, it's an indication if you've got a stent, because you can read it then.
Yes, you can, although you're not going to be able to see what's inside the stent.
Right, but then the other thing that I always order, when I do a CTA, now I've got to look at my orders, it's like, I don't know what my wife's phone number is because it's always on my cell phone. There's something called it's a fraction or something that goes to...
Fractional flow reserve?
Thank you, fractional flow reserve.
Yeah.
And I always order that. I was told and educated to usually or try to always order that together with a CT angiogram under those conditions where you're not sure whether the plaque is 20% or 90%. Can you explain that a little bit?
Fractional flow reserve is something that's mostly used in heart catheterizations. And there's different ways of looking at it, but it's when you put a medication that will dilate the heart, you look at how much the pressure drops across a lesion.
Right.
And if if it drops beyond a certain amount measured by different things, then that's significant and it will probably benefit from an intervention. It can also be calculated with PET, cardiac PET. You can do very good fractional flow reserve to calculate percent stenosis.
Right, and isn't that what we're looking at? Isn't that the purpose?
Yes, that is the purpose, but it's not always, not all the software can do it.
Yes, I know this. You've got to make sure that they've got the software to do it.
Yeah, and where we are, we don't have the software for that.
Okay.
But fractional flow reserve can be done with, again, card catheterization when you're putting wires down and injecting.
Right, but that's done, yeah, and that's looking at the gradient.
Invasive.
Yeah, but I'm
the
talking
cardiac
specifically on the
PET,
CTA.
A cardiac PET is a newer technology that is in many ways more accurate, more sensitive, more specific. But
A regular PET scanner can do it?
well, it's a cardiac PET. It's a gated PET, and because it's a very short half-life, and we're talking seconds here, that it allows you to do a flow reserve, but also you need something that's called attenuation correction. So you need a CT scan, so you can actually get a poor man's Agatston score.
On top of each other.
You can get a calcium score. So if you do a cardiac PET, you can get something very similar to and some of the newer ones actually will give you a reasonably good calcium score. So that's a very important thing.
And what about an MRA? Is MRA used for this at all?
It can be. Again, that's magnetic resonance, which is different.
We use MRAs for the liver, for
Yep.
MRCPs. We use it for flow in the belly outside of the heart. I'm not a heart guy. You are.
Right. So with MRAs, we primarily look for if we're thinking there's an infiltrative disease, if we think someone has sarcoid, if we think that they may have something called right ventricular cardiomyopathy, where part of the heart is thick and might require a defibrillator, we're looking for some type of abnormalities in the valve, but mostly in the myocardium.
But it's not a good screen in place of a CTA.
That's correct. You can at some hospitals do a cardiac MR that is stress. Other hospitals will not do it because it's a very specialized thing, and usually that's at the bigger institutions that they will do a stress MR. Many will not because they get paid only a certain amount of money and they're not going to want to do anything more. That's what the hospital.
I'm going to ask you this question. You can refuse to answer it quite happily.
Okay.
What percentage of the decision-making protocol of which tests to do is governed by the economics versus the knowledge that you gain from the test?
The economics is always important, and you have to look at things like I'm going to play right back on you. You're not seeing Medicare patients anymore.
Correct.
I have no choice but to see Medicare patients. If I see a Medicare or a Medicaid patient and all I do is a medium-level consult, a medium-level visit for 15 minutes, I will lose money.
Yes.
So amortized over a year or a 2-year period, we do need to, and of course, fortunately, in a consultative cardiology practice, we're going to do other tests because that's what we're being sent
You're getting paid for the test.
Right. You're getting
the
paid
visit
for the
is
test.
just to justify the test.
Exactly, because you have a referring doctor says, I have a question. Has this person changed in the last 2 years? Or, I don't like this EKG. I'm worried. Their family is worried. Please answer this question. Yeah. So, yes.
They don't want your opinion. They want data.
They want data. So they want to know what's the likelihood that something bad is going to happen to their patient.
You know, but that's fair enough. But it's the economics make me hold my nose just a little bit. So let's talk about. I really want to go now. This is where my knowledge base is.
We can talk about pets sometime in the future, and ketogenic diets. That's
we're going to talk. But the most important thing is your real hack, which is the electrophysiology.
Right, I understand.
So let's talk about arrhythmias. And the one that we see most, let's work from what I consider to be the most common and worst one backwards, which is atrial fibrillation.
Yes.
Obviously the deadly ones, but atrial fibrillation, very common. What is it? How do people get it? And how do you treat it? And should you treat it?
Yes, you can treat it. It is, on the whole, the most common cardiac arrhythmia in all people.
Is that new?
No. Atrial fibrillation has been around.
It's been around for a long time, but I'm seeing so much more now than I did when I was a medical student.
Yes.
Why?
People are older and metabolic syndrome.
But we're seeing people in their 50s.
Yes.
These are not old people. when I was a medical student, people were in their 50s as well.
There's some new.
So I'm really looking at the metabolic side.
Oh yeah. In fact, I gave you a little.
Yes, I've got
sheet
that here. Yeah.
On there, there were new guidelines that came out with atrial fibrillation, American College of Cardiology, Heart Rhythm Society, and part of it was staging it, like pre and risk factor, and all of that stuff's interesting, but not really relevant to this. But the interesting thing is that they brought up several things that need to be modified to prevent or to treat. And start it off with, not like the federal agency, but alcohol, tobacco, and exercise.
Okay.
That's the thing. The three things were alcohol. Unfortunately, sadly, there's nothing good I can say about alcohol when it comes to AFib. It will increase the risks. It's arrhythmogenic. It's fibrogenic. It doesn't. I'm sure that there's a tolerance, but sadly, that's
so
what
alcohol's associated, nicotine's associated.
Yeah, well, it's also not just the nicotine, although nicotine, yes, but it is the vascular damage that you are doing inside the heart.
So, but I use the word nicotine, not smoking.
Right. Yes, because of
vaping and everything else. Yeah.
So alcohol, tobacco, and lack of exercise.
Okay.
And being able to exercise again is such an important thing. And so that's one of so these are the risks as well as the interventions. And the part of them, the first three I mentioned.
How does making your heart work harder reduce the risk of arrhythmias?
Within reason. If you are an ultramarathoner, if you're a triathlete, I mean, those absolutely are
I'm talking about your standard 3 hours a week.
3 hours a week.
Which is the recommendation from the
among
World
other
Health
things, it
Organization.
improves your insulin sensitivity. It tends to...
But you see, that's not exercise. My diet can do the same.
Yeah, I know that.
So that's why the question was, how does exercise...
You're asking for a textbook answer.
I'm asking for your learned answer.
Okay. Exercise will improve your VO2 max. It improves your ability to do work. It improves your muscle mass. It will hopefully lower blood pressure and may facilitate some degree of appropriate diuresis, keeping your plasma volume lower. But it's just one of these things.
I would argue with you
that
exercise is the pimple on the American elephant's ass.
Uh-huh.
The elephant is diet.
Yes.
Because everything you just talked about is irrelevant if you are eating a bunch of carbohydrate crap.
Right. Well, I've lost most of my weight with minimal exercise, as you know.
There you say it. So, I just want to put that into perspective. I'm
quoting the American College of Cardiology.
Right, no, I hear you. But I do exercise every day.
Yes.
So it's an important part of my lifestyle.
Yes.
But I don't place cardiovascular... The foundation of my health comes from a change in my diet.
Mine too.
And I think that's an important concept because all too often people are pushing you to exercise, and when you exercise, don't you need carbohydrates to exercise? So isn't that... No, I know you and I know that, but what I'm saying is I'm quoting the textbook of cardiology.
Yeah.
and it's such an upside down thing. Let's focus on the priority, which is improving the metabolic nutritional impact.
Well,
and then add the exercise.
That's exactly because, again, there are 6 things that they mentioned. Those were 3: alcohol, tobacco, and exercise. And the second ones were weight, blood pressure, and obstructive sleep apnea. And when I saw that, I started cracking up. I said, this is all insulin resistance.
Right, but not only that, I will take the diet. I'm more afraid of the skinny diabetic than I am of the fat guy. So again, that's a subtle thing the back half of this are some of the metabolic insulin resistance.
But they don't understand it. That's the thing.
Okay.
Obviously, weight and blood pressure.
But what did you not mention?
I'm just talking about.
No. You didn't mention lipids.
That's correct. That's not in the risk factor and modification for atrial fibrillation.
So you can eat as much fat as you want to. You're not going to. It doesn't matter.
No, they assume that you're going to be doing lipid diet
on a statin,
yeah, and you'll be on a statin and about diet hard. Yes, we can discuss that.
Yeah. We'll get to that. No, I'm being facetious, obviously there, but
yes.
So those are the risk factors for arrhythmias, and I'd flip them. I'd put the most dominant one to be the metabolic side.
Absolutely.
Yeah. Good.
Absolutely, because the metabolic side is going to contribute significantly to your hypertension, to your sleep apnea, which absolutely triggers atrial fibrillation.
Is that because of hypoxia?
It's because of hypoxia and
Not
fatty
just
tongue.
internal pressure, not just...
No, because when you obstruct and you drop, you're going to cause vagal response as well too. You can slow down, become bradycardic.
But you see, it's related to obstruction, not I work sometimes at 5,000 to 7,000 feet of elevation. My SATs are 10 points lower.
Yes.
But is that going to increase your risk of having a arrhythmia?
If you're not breathing at the time, and your CO2 is going up and your PO2 is going down.
So it's the obstruction, not the desaturation.
It's probably a combination of that and how it affects the vagal effects on there. Because we know obstructive sleep apnea, one of the reasons we look for pauses, and sometimes we will put in a pacemaker, assuming someone is wearing their CPAP, or has had their uvulopalato-pharyngeoplasty.
Terrible operation.
Yes, I agree with you. Treating fatty
doesn't
tongue
fix the problem.
with LCHF is the gold standard as far as I'm concerned. But very few people believe me.
No, I agree 100% with you in that regard. And I see a lot of them, and the results are awful. So okay, so we've got the metabolic contribution, and it's primarily atrial fibrillation that is caused, not the other, bundle branch blocks, not the other arrhythmias.
That's a good question.
Bradyarrhythmias, tachyarrhythmias.
Well, that's actually a really good question, and I haven't gotten a chance to talk to her, but Karen Zinn is doing some work on diabetic cardiomyopathy, which is a term not used a lot in America. And I just hadn't had a chance to reach out to her, but the stuff she's doing is very interesting. I really suspect that it is involved with bradyarrhythmias, with bundle branch block, with not so much SVT, although that could be some fibrosis in there, and not with WPW. That's an inherent, that's something you're born with.
Yes.
But with ventricular arrhythmias, heart block, certain types of what are called atrial tachycardia, which is related to AFib, but you don't need anticoagulation. But yes, diabetic cardiomyopathy is very important. And you know, she's the editor of our journal.
I know Karen very well. South African that was displaced in New Zealand. She's wonderful.
You're all South Africans.
They're all South Africans. We're all South Africans. Okay. She was at Noakes's trial, but I was the one that reached out to her to get the journal changed to her. I'll just put my own little plug in there.
I also know that she's one of Tim's angels too.
Yes, absolutely.
I did read the book.
Yeah. No, she's wonderful. Karen is wonderful, and doing great work in New Zealand. She's a dietitian. Doing great work in New Zealand with Maoris and with diabetes and that kind of thing. Fantastic work.
Yeah, she did an interesting thing with a Ph.D. in one of the nurse midwives.
Yes.
Published some stuff on there. On there because I've got master's educated nurses in my family, so going back for some time.
So let's get back to so atrial fibrillation. What is atrial fibrillation?
Atrial fibrillation is a fast, irregular heartbeat of the top of
fast.
the heart.
It is always at fast.
Yes, it is.
You hear about slow rate atrial fibrillation.
Yes, and that's because of the AV node. Basically, there are some protective mechanisms that your body has, so that you don't die from heart arrhythmias. When people get a little older, if you're 20 years old, you can easily get your heart rate up to 200, 210. Your young son can get
normal
his
heart rate is
up
120 to 160 for a newborn.
Yeah, you can easily get his heart rate up to 220, 230, probably not even notice it.
Yeah.
But as you age, like we have, you need to be more careful. It's like putting a governor on a car's tachometer so that you can't push the engine too fast because you don't want to blow the engine.
Right.
Well, naturally, the AV node, which is the junction box, will prevent the top chamber from... The top chamber will still go fast, but it will not allow the bottom chamber, which is the big pumping chamber, to go too fast.
So there's an electrical disconnect through the AV node.
There is a point where it
will
disconnect.
But isn't that called a block?
That's normal. That's survival.
But that's a normal block.
That's supposed to be, exactly. You will develop a physiological heart block if you're our age and your atrium decides to go to 220 beats a minute, which will be very hard with any amount of exercise to get it there. You're probably going to block, meaning it'll go to 2 to 1. So instead of 220, it'll be 110. You might pass out. Yeah. But it's to prevent you from having a 200 beat per minute.
And then you got no stroke volume.
And then you'll drop dead potentially. So it's
I just asked that question about the rate, but atrial fibrillation is usually fast.
Yes, the top chamber is always fast. So there's atrial fibrillation and atrial flutter. They're both very similar. atrial fibrillation is generally with a rate greater than 300 beats per minute. In fact, so fast that
the atrial beats.
The atrium is not even contracting. It's not contributing much of anything. It's a fasciculation. That's the better description of it. But since it's firing, it's going to send an impulse to the AV node, and if the AV node listens, it'll make the bottom chamber go to 200-300 beats a minute, which is
the ventricular tachycardia is dead.
You die. So your body has a natural protective mechanism to hopefully prevent it from going too fast. If it's not good enough, we will give you AV nodal blocking.
Now, why does it happen? Why does it happen?
Why does atrial fibrillation
Yes.
happen?
What is the source? What is generating that? Because it's got to be electrical. There's got to be an electrical pulsation that is just very rapid.
In the old days, we used to think, well, the heart's gotten stretched out, the atrium is stretched due to high blood pressure or valvular disease. It's stretched out, and when it gets stretched out, it gets boggy, and it just can't contract. Well, yes, partially. But what happens is the areas in the pulmonary veins, which are the four veins coming from the lungs with oxygenated blood that dump into the atrium, which gathers it all together to put it into the big pumping chamber. Well,
they're actually arteries.
They are arteries.
Because they're bringing oxygenated blood back, but they're veins because they're coming to the heart.
Through the heart, yes.
That's how I always looked at it in medical school.
Yeah, absolutely.
But they've got a high oxygen capacity.
Yes.
And they should have the lowest level of sugar of any blood coming back to the lungs. They're coming back to the heart.
Yes.
Of all the blood coming to the heart, they should be the lowest level of glucose.
That makes a lot of sense.
So, I mean, again, if you think about it, it's gone through the systemic circulation, then through the pulmonary circulation, and then back to the heart.
Right.
So the gradient between the aorta and the pulmonary artery, well, I guess they picked up oxygen, but they, in terms of glucose, should be the lowest. In terms of oxygen, should be the highest.
Yes. So with the pulmonary veins, the muscle that is in the atrium will frequently, embryologically, have worked its way up in that. So
wait. So there's a difference between the endothelium, or the lining of the cells in the vessel, as opposed to the heart. They're different.
Yes.
And what you're saying is metaplasia, which we see in the esophagus for reflux. Those cells grow up in little tongues into the...
And that happened embryologically.
So that is there at birth?
Yes. It goes in different amounts with different people, but there's some degree. So those areas in the pulmonary veins that have myocytes that can function on their own, that can become irritable and start firing, if that vein gets stretched out, so
they can become electrically active.
They become electrically active. And
so myocytes are potentially electrically active. Right. Endothelial cells are not.
Yes.
Where's the SA node? The one that fires?
That is on the right-hand side. It's in the high right atrium.
But it's in the atrium. It's not anywhere near the.
No, it's in the high right, and it goes along something called the crista terminalis, which is basically a number of different backup SA nodes, which can cause other problems.
But the SA node is the guy that's supposed to trigger the
main pacemaker of the heart.
So this is somewhere far away.
It's not supposed to be there.
Correct.
It's not supposed to function as a pacemaker cell. These are things that go off on their own, like.
So it's not a new nerve that's grown. It's not nerve damage. These are cells that are supposed to be muscle cells and endothelial, specialized endothelial cells that are now becoming electrified.
Because cardiac muscle will tend to beat on its own. You put a bunch of cardiac muscle cells together, they'll all sync up. Well,
say that again.
Cardiac myocytes are different than skeletal muscle and smooth muscle. They have an intrinsic beating rate.
Independent of things like the vagus nerve.
Correct. Independent.
So by themselves, if I cut them out, put them in a petri dish.
Yes.
So
you'll see them.
You'll see them bouncing.
And if you touch them together, then they'll all start to sync. They'll all go together.
And that's electrical, not magnetic.
Yes. That's because of the communication between the cells.
Interesting. Okay.
So you've got myocytes that have a tendency to beat on their own. And that's part of the problems with PVCs, because you've got some cells that are designed to go off on their own.
I want to get back to PVCs in a second. Let's hold on to that.
But so it's the same type of mechanism. There are either early or late after depolarizations. That doesn't matter. Just basically, it's tending to want to go on its own, and they tend to be in the pulmonary veins. And when we found out...
And can you map them?
Yes.
How precisely?
Within a couple of millimeters.
Okay, so
but we don't need to.
Well, you're going to burn them, aren't you?
Yeah, but we don't need to. It's sort of like the difference between a .22 target rifle and a shotgun.
Okay, so you're going to hit them with a shotgun.
The whole idea is we know that this is coming within the there's the ostium, or basically where the vein dumps in,
right?
And all of this activity is within the first couple of centimeters. Even if it's 5 centimeters up, it doesn't
matter. So if you
matter.
disconnect the circuit, if you just fry, so you do the whole ring.
You just either with RF energy, or
what's RF?
Radio frequency energy,
okay,
where you are burning it,
yeah.
Or you can use a cryo balloon, where basically you're putting cold stuff in there and freeze it, and you.
Which do you prefer?
The cryo balloons may not be quite as effective, but they are faster and they are in many ways safer. The chances of getting a stenosis of the pulmonary
caused by scarring.
The scarring.
Yeah.
You don't want to scar it down and close it off, because now you're not
going
to
to
fill your heart.
Yeah. And do you do all 4 vessels?
Frequently, but not always. What you do is you map them, and you look to see, hopefully a person will be in sinus rhythm, and you're looking for activity.
If they're in atrial fibrillation, does that make a difference?
Yes, it depends how you're going to do it. And again, I haven't done these in a couple of years. This is something that the hospital where I'm at, we don't do. That has to go to a bigger area. There are times that you can go right in and just start to isolate each of them, which is frequently done. And it's usually that's not the only thing that's done. They will normally do a roof line, which connecting the top veins together. Sometimes if there is an atypical, what we call atrial flutter, we may do a flutter line on the left or on the right hand side. And sometimes, depending, most of the time people are going to be in a normal rhythm, and we look for the electrical activity in the veins. Ideally, what we do is we'll isolate one, and then we'll check to see, is there a block? Can an electrical current go from the atrium up to the vein? And can it go from the vein to the atrium? And if you can't, you've got blocks, so that means you're isolated.
Yeah.
And then you move on to the other one. And if you find an electrically silent vein where there's nothing going on there, there is an argument for not ablating it.
Yeah.
In there. And
is that where they recur then?
What frequently will happen is you can get reconnection, where those little muscle cells...
so they bridge across as the scar forms.
Bridge across the scar.
Okay. Because I know we do frequent... I mean, it's not just one ablation. You tell people...
60 to 80% success for the first
and how many ablations is a reasonable number to do before you say, well, you're on your own, you've got atrial fibrillation for the rest of your life?
And generally the first ablation will be a classic PVI. We tend to do 4 veins, tend to do a roof line. And if there's no other arrhythmias and they're back in a nice normal rhythm and there's no evidence that there's any thing coming from the veins, then see what happens. If they go back into atrial fibrillation, they then now have the option of, well, we did this to make you feel better, get you off of medicines. We'll put you back on medicine, see how things go for a while. I tend to have people wait 6 months to a year.
So there's the time interval. Mm-hmm. The quicker you do it after you relapse into atrial fibrillation doesn't make a difference.
Well, what you want to try to do is keep someone in sinus rhythm. So a lot of times after an ablation, if you go, let's say you're going back into AFib in 4 months.
Right.
And either you're going to be in it all the time, and usually when you go in it, you're in an atypical form, which is not as easy. I will generally place them on some type of antiarrhythmic, which generally will put them back into normal rhythm. So
Entresto comes in, one of those?
No, it's actually amiodarone or Maltac.
Okay.
Or flecainide under certain circumstances. So it will vary.
Okay.
And then the option is, hey, we can try this again. You probably have a high success rate. And then the options become, well, do we want to go back in and look to see if there's reconnection? Some places and certain hospitals in particular push what's called a convergent or a hybrid procedure, where it's like a guy like you and a guy like me together, where you would have a surgeon go and epicardially work on those ganglion plexus that we talked about.
Right, so you cut the vagus nerve plexus.
Yeah, not so much that, but
you isolate
innervation. You isolate innervation in the back. You also will clip the left atrial appendage, so you don't have to be on.
Right, so there's no clots up at the top. That's like a Watchman type
procedure. And depending, frequently they will go with a clip, AtriaCure, and clip from the outside. So you got it from the outside to the inside, and then after that, and sometimes they'll do it the other way around. But then after that, you go back to the EP, who looks on the inside to map and see, hey.
Oh, so you do a combination procedure?
Yeah, to see, is there any places that have been missed?
Right.
And so we clean it up both on the outside and on the inside. That's a convergent procedure. It doesn't work well if you've already had open.
But that requires,
surgery.
I was going to say, that
no,
requires...
it actually doesn't.
You can do it minimally invasively?
There's a xiphoid incision about so big, and a
cardiac window.
And a left side incision there for the left atrial appendage clipping.
Yeah.
So it's a truly, nowadays, considered minimally invasive.
Okay. That's nice. That's kind of my wheelhouse over there.
Right. And I think that's a great option, and we use it more. I will use it for a first-time AFib. I'll refer for that. There's a couple of hospitals that do it near me.
So you'd be more aggressive the first time?
I would be more aggressive with somebody that's in long-standing persistent atrial fibrillation.
Okay.
I'm sure he'll be fine with me saying my next door neighbor had long-standing persistent atrial fibrillation. He did not have an ablation. We talked about it for a while, but he had other medical issues that prevented him from having that type of thing.
Right.
And he'd been in AFib for more than a year. He did very, very well.
With that combination?
No, we didn't.
Oh.
Well, I said, well, we could go ahead and do that.
Yeah, it was too sick.
No, he was actually good by then. And I said, well, there's two ways of doing it. There's the more complicated way, and then there's the straightforward way. And we did the straightforward way, and he did great.
Wow. Okay. Good.
So that's one of the things.
Let me start. There's one
but
question.
We can always do the second part later.
Right. So you can come back and do it.
Yes.
So here's another question along those lines, because when you do procedures, we can always come back and operate. It's a different position if you're on the other side, if you're the patient. I often say, we'll come back and fix this later, or as a surgeon, it's easy. It's what do we do for a living. You don't put yourself necessarily empathetically in that patient's life. But here's a real question. I have read some studies and looked at information where the cardiac enzymes go up in a significant percentage of patients when they have a heart cath. This was a cardiac cath
that was an
study,
old study.
And the cardiac enzymes went up, which basically is a heart attack.
Sort of.
So break that down for me, because this is the rationale by this. The one paper I particularly read is, look, if you come into the emergency room and you've got chest pain, your enzymes are up, they make a diagnosis of a heart attack.
Right.
But if you have a cath, this I can't remember what the context was, but when you have a cath and your enzymes are up, where are those enzymes coming from? Is it not the same thing?
It depends, and there was an old paper that I'm familiar with, as in like back when I was in training. Anytime there is decreased blood flow to the heart muscle, there will be some enzymes released. And literally to the point, if someone came up to you and punched you really hard in the chest.
Or the car accident.
You can easily, I'm not even talking about a hard punch.
Right.
Or sidekick. It's something that's not that much. You can have a subtle bump in your cardiac enzymes. And that technically is a type 2 non-STEMI or non-ST segment elevation MI.